Good evening, everyone. I welcome one of the most reputed and I would say the authority in focus, fluid resuscitation, ultrasound in critical care, and research in counseling, communication. And we have so many other things in his CV, which I would be sharing. So myself, Dr. Tapas Kumar Sahoo, I am the course director for this course. I welcome my co-course director, Dr. Sananda Kumar Das from Australia, and also our guest faculty for today evening, Dr. Adrian Wong. He is in King's College Hospital, London. He is the consultant in anesthesia and intensive care. And we all know he has many things to his credit. He has an interest in the use of point of care ultrasound to guide fluid management, especially around venous congestion and organ perfusion, and also human factors in the time critical environment of the ICU. His other research interest includes clinical governance and safety, medical education, and burnout and well-being. He's a member of the Intensive Care Society, FUSIC committee. He is an examiner for the EDIC. So that is the best part for today's class, that he takes the examination for all the EDIC part 1 and part 2 regularly. So we can take the tips and tricks from him, and that would be definitely useful for the candidates to appear in the upcoming EDIC 2. He was the ex-chair of the Social Media and Digital Content Committee of the ESICM and course director of the Genius Ultrasound course. He is on the executive committee of the International Fluid Academy. Welcome to our today's discussion, Dr. Wong. We are privileged to have you in today's discussion. Despite your clinics today, you are on call, despite you have consented to be part of that. So that we really take in our for the candidates betterment, and we would definitely be benefited by your experience and expertise. I would request Dr. Wong to share his experience as an examiner of the EDIC for last couple of years.
Thank you very much for the kind invitation to share with you some ideas and thoughts. So the brief I got given was to tell you a bit about what to expect at the exam, and perhaps more importantly, what the examiners expect of the candidates. So it's a bit of background. I've been an EXICM EDIC examiner for the last 7 years or so. So I've seen multiple exam centers and examined both in person and more recently on the online version. But broadly speaking, the exam is divided into 2 parts. A clinical case scenario where you are going to be presented with clinical information and essentially work through the case. And the second part is on what we call the computer-based scenarios, which is further divided into 3 parts. And we call them the images part. So one is images around radiology. One is images around traces and loops. And the other one finally is around biochemistry. If I talk a bit about the individual parts first and how you go about approaching it. Let's start with the computer-based one first. Generally speaking, the computer-based scenarios is a test of knowledge. And what I mean by that, it's, for example, the images one, it's usually along the lines of, what does this image show? What would you do about it? As a trend, the questions seem to be moving towards what would you do, rather than what is the diagnosis as the one single question. Because the bottom line for this exam is that you need to be of a standard where you can run a intensive care unit using contemporary European ICU practice with minimal distant supervision. So this is exam tailored for people towards the end of their training or have finished their training. That's the first thing to say, which is very different from some exams out there, which are sort of in the UK taken at the middle bit of your training. So when we come back to images, usually it's a collection of X-rays, CT scans, Ultrasound is in there as well. You are not expected to have super specialist knowledge. These are the sort of scans that we expect you to be able to see, diagnose, interpret in a normal general intensive care unit setting. I think personally, I think the imager section is usually the most straightforward of the three computer-based ones. Read the vignette. In all three of these parts, there's usually a brief introductory sentence. Read it. More often than not, the vignette will give you an idea in terms of what to look for in the following images. So don't be distracted and jump into the image straight away. Have a look, have a read of the vignette first. When it comes to the loops and traces, these will be things such as ECGs. It will be things such as the PA catheter waveform. It could be things such as an ICP trace. It could be things such as the ventilator flow volume loops. Now, if in your practice you don't look at any of these things on a regular basis, make some time to review them, be it online resources, textbooks, or what have you. I think it's important to it. Things that sometimes catch colleagues off guard or you may not come across on a regular basis, PA catheters, ICP bolts, what's the other one? Balloon pumps. Flow volume loops, it's variable. So some countries and some colleagues look at it on a regular basis, other people don't. There will almost certainly be a question on that. The final one is the biochemistry one. I've said before that you need to read the vignette. This is the most true and most relevant for the biochemistry section, because more often than not, there is quite a lot of information being presented. If you look at the vignette, it gives you an idea to what you need to be looking out for. More often than not, by the time that you read the vignette, you know, you can sort of guess what the diagnosis is or what the examiners are trying to steer you towards. Okay? The difference between this set of exam, the computer-based ones, compared to the clinical case scenarios is that you, roughly speaking, each station is about 12 minutes or so. If you go through the questions, if you still have time at the end, the examiners can bring you back to ones that you skip. So if you look at something and you're not sure, you can say skip. Okay? And if there's time at the end, you can go back to it. The examiners are not allowed to prompt you. That's the first thing. There's the other thing. Okay? If we move on to the clinical case scenarios, these are cases where you are given quite a bit of information at the start. You are given about 5-10 minutes to make some notes on the cases. I would suggest that you use this time you're allowed a pen and pencil as tools during the course of the exam. Make some notes, summarize the case, highlight, write down the bits that you think are the most important. The first question to the clinical case scenario is usually along the lines of what do you think the diagnosis is, or how would you manage this case? Approach it from the point of view of what you would do if it was you on an ICU. If that patient was on your ICU, what would you do? Okay? And that's usually the safest way of approaching things. What would you do? The difference between this section type of exam, the clinical cases compared to the computer-based ones, is that the examiners will move you along in order to cover the whole of the clinical case. So if you don't know, you can say skip, but you cannot come back to it. Because once you reach a certain stage of the case, the examiners will present you with more information. So for example, the first set of information might be, you give you the clinical history, they might give you some CT scans, and then the early questions might be summarize the case, how would you manage, what the CT scans show, what other investigations would you like? And then the second vignette, once you reach that stage, is the examiners might present you with a blood gas or something, or a urine analysis or something of that sort. So you can't move back once you've moved forward. So that's the difference between the conduct of the computer base and the clinical case scenario. Sometimes in the clinical cases, like in real life intensive care medicine, there is no true right or wrong answer. So the questions might be something along the lines of what are the risks and benefits of treatment X? So you need to give the risks and benefits of the various different options. And usually the question will say, what would you do? You give your choice and justify it. It's very, very clinical. And probably that's the reason why I like the exam. Most of the cases are very relevant to contemporary intensive care practice. I know that in this course, you'll be exposed to examples of the computer-based and clinical case scenario. So that's all I'm going to say about the structure of it. In terms of what we are after from exams, like I said, the benchmark has always been, you need to be at a standard where you can run an intensive care unit with minimal or distant supervision, okay? That is roughly speaking, the standard. You need to be able to get your knowledge across. Generally speaking, candidates coming to the EDIC exam, I don't think, the ones that struggle, I don't think it's a problem of knowledge. So these candidates often have read the books, read the literature, so on and so forth. But it's how they apply the knowledge that sometimes don't get across easily to the examiners. So when you are examining or being examined, think about what you're going to say before you say it. If you say everything that comes into your head without considering it, almost like a machine gun approach, it won't be counted favorably towards you. We want to see organized, structured, clear thinking processes. So in some life support courses, they like the structure, airway, breathing, circulation, disability, exposure, ABCDE approach when faced with a critical incident. So you need to have something along those lines so that your answers are balanced, considered, and structured. The examiners will know. So for example, if the question is, what's the differential diagnosis in this case? And if you say something along the lines of, well, it could be diabetes, it could be hypertension, it could be a stroke, it could be an MI, it could be COPD, it could be asthma, and literally say everything that comes in your head, that won't necessarily count in your favor. It's far better to say something along the lines as well. I think the differential diagnosis, atrial fibrillation of ischemic heart disease and diabetes. The reason why I say that is because the history of this is this, the biochemistry shows this, and the response is this, something along those lines. Okay? Again, if you don't know the answer, you can try to work it out. For the clinical case scenarios, the examiners are allowed to prompt you once to try and get you along the correct line. So they might say, tell me about your management strategies for this patient. And you might say, I would optimize the ventilation. I would optimize the vasopressor requirements. And if you're missing anything, the examiners might say, and is there anything else you would do? And hopefully you'll say something along the lines of, oh yes, I think this, given the fact that this patient is septic, I would take blood cultures and administer broad spectrum antibiotics. Something like that. What else can I tell you that will hopefully improve your odds? Practice. So most of you who are preparing for the exams, I'm sure, will be hard at reading the books, reading the papers, reading the journals, so on and so forth. It is not quite the same as being vivid, which is essentially what this exam is. So the more comfortable you are talking through cases, explaining your rationale and management strategies, the better. So if it means attending courses such as this one or practicing with other colleagues, either face-to-face or across Zoom, Teams, whatever you use, do so. Because it can be quite intimidating doing it for the very first time, and it's your exam. The other thing I would suggest is in terms of the logistics and setup, most of you would be connecting to the exam using a Wi-Fi network, and that's fine. But we have issues with colleagues not being able to dial in because of poor Wi-Fi connection, etc., etc. So from a technical side of things, if you can use a wired internet connection, that's usually more reliable compared to Wi-Fi. Make sure your room is quiet so you can hear the examiners, and perhaps more importantly, the examiners can hear you. And I would also advocate trying the internet connection, testing the internet connection at the time of the exam itself, because there's a time difference. So we all know that after work, everyone wants to go and watch Netflix or something. And if that corresponds with your timing of the exam, Wi-Fi connection will become compromised by it. These are all things that the exam information will send to you once you've been accepted for a place on the EDIC exam. But these are practical, simple things that I think sometimes people take for granted. I've examined people where there are motorbikes you can hear running in the background or children in the opposite room. It doesn't help. It won't help the candidates and certainly won't help the examiners. So just bear that in mind. I think that's about it in terms of what I wanted to say to you. If you've got any questions, I'll do my best to answer them for as long as I can stay. Tapas, is that okay?
Yeah, perfect. Yeah, thank you. Thank you. That was really comprehensive, and definitely that would improve the odds and the confidence of the candidates for the upcoming exam. So any of the questions from the candidates, or we can start with the CCS and CBS mock exam test so that you can know how the answers normally being given by the candidates and what should be. So yeah, so there is a question from Dr. Arun. What type of answers the examiner expect? So
The correct one.
that's the best one.
I think this, no, all joking aside, I think it depends. I think it depends on the question. So I think if the question asks you, for example, what is the diagnosis, then be clear and say, I think the diagnosis is X. You'll be surprised because of stress, because of nerves. The question says, what's the diagnosis? And some candidates talk about the investigations they would do. You need to answer the question. So read the questions.
Yeah, perfect. Yeah, exactly. First, you listen to the question properly, and then you frame your answers in meantime in your mind and answer it confidently and connect the dots. Rather, it is normal, not advisable.
All the questions, absolutely right, Tapas. All the questions are usually very, very reasonable questions. Obviously, some of them will be hard, but especially relevant for the computer-based ones is the fact that you need to read the vignette. Read the vignette, okay? It gives a lot of information there. If you just quickly look at the loops without reading the vignette, you make it twice as difficult for yourself. Okay, there is a question there. How is it divided into 2 days? This is the last sitting of the exams. Is the first time we've divided it into 2 days. And what we've done is that you will sit your computer-based scenarios on one day and your clinical case scenarios on the second day. This is, I'm not part of the exam committee, so I don't know if that format will stay or not. But that was what we did at the last sitting. So if you are on the right line, the examiners are allowed to prompt you once. Now, equally, if you said if the question is what's the differential diagnosis, and you've got 16 million diagnoses and you've mentioned 3 or 4 and it happens to be the correct one already, the examiners might interrupt you and move you on because you've already got the answers. So don't be disappointed if the examiners move you on, because it may just be you've already said the answer they want and they want to move you on to give you more time for the other questions.
And nowadays, they want to know more. They expect us to know more details about the ART,
They will
like
ask
HIV
you.
medications and chemotherapy. All in details they are asking nowadays.
I think it's
Oncology.
important that you know there are big things in intensive care in terms of chemotherapy. No one expects you to know every single chemotherapy regimen out there. But for example, you should know about CAR chemotherapy, CAR T chemotherapy as an example, or some of the newer immunomodulators ones, for example. I don't think you need to know the specific doses of cisplatin or what CHOP-R chemotherapy is. But yeah.
Yes, but definitely compared to 5 years ago and now, the questions would be more comprehensive and they expect you to know little bit in depth. It should not be superficial. Yes.
I think
Am I right?
so. Well, I think of it, well, in depth when it comes to our core business is probably true. So in depth when it comes to hemodynamic management, PA catheters, renal replacement therapy, I think that's true. We're not supposed to be able to test you on super specialist knowledge. So, for example, the latest, I know the minuscule doses of the latest chemotherapy agents for multiple myeloma, say, for example, I think that's a bit unfair. But having said that, I'm not on the exam committee, so I don't set the questions. But generally speaking, when I've examined the multiple sittings I have, most of the questions I think are fair.
Yeah, Tapas, Adrian was correct actually. The dimensions of critical care has expanded so much that previously when we were trained, oh, this is not a part of ICU we thought about, but more and more things are coming into picture, like the CAR T therapy, complications of that, immune modulator, immunosuppression, reversal, all those things are very important. And as it is becoming more and more specialty based, so the expectations are rising. So don't think that these are not relevant to ICU, because and all the questions that will be asked or are asked are always relevant to ICU practice. So it's that the candidate doesn't know or hasn't seen that case. That's the case on that day. Otherwise, it's not out of the syllabus, I will say, in a line.
No, but that's part of the fun of working on intensive care, is that it's an exciting specialty, isn't it? The developments are definitely there. So I think trying to fix just numbers, which is sort of the old way of practicing intensive care, I think is gone, and certainly not the intention of this exam. So you need to be good intensivists.
Correct. Yeah, correct. Yeah. So, Dr. Wong, thank you very much.